Media is the middle layer of visceral muscle, fibrous tissue encircling the vessel to make sure that it stays very firm with considerable elastic tissue, again allowing for that high pressure for the arterial part of it. Tunica adventitia is the layer of connective tissue surrounding the middle coat and is the outermost portion. Okay. The physiology of circulation. So blood flow refers to the amount of blood that passes through the blood vessel in a given period of time. The blood flow is determined by two principal factors, blood pressure and also resistance. Blood pressure and also resistance as it applies to blood flow. Blood pressure refers to the pressure in the arteries. It is basically the force needed for the heart to pump to the resistance of blood flow. So an increase in the heart rate or force will increase blood pressure. An increase in the heart rate or force will increase blood pressure. An increase in resistance of blood flow will increase blood pressure. Do you guys know that blood pressure and heart rate are inversely related? Blood pressure and heart rate are inversely related. So when the blood pressure goes down, oh no, let's do this one more time. When the blood pressure goes up, the heart rate must go down to maintain the same amount of volume being circulated. Because if blood pressure goes up and heart rate goes up, you're going to be pumping out a lot of blood. So we're trying to maintain balance. Blood pressure goes up, heart rate goes down. So if blood pressure goes down, what do we need to do to maintain balance? The heart rate has to go up. It has to go up. Maintain volume. An increase in resistance of blood flow will also increase blood pressure. The average pressure is 100. So they're talking about the average between your systolic pressure and your diastolic pressure. Do you guys remember what each of them means? So systolic refers to what? Contraction or relaxation of the heart? Contraction, okay? And diastolic is referring to the relaxation in the heart. So the average pressure is at 100 or 120 over 80 millimeters per mercury. So in reference to the ventricle, again referring to blood pressure, the blood fills the left ventricle from the left atrium. And so as blood is filling up the atrium, the pressure starts to rise. Okay? And once it hits maximum pressure around 120, this is again your average normal individual. Once it reaches 120, it'll cause the aortic valve to open up, allowing the blood to flow through, and the pressure drops again from 120. Okay, and this is where you get that lub dub. Remember in your heartbeat? Goes from 120 to 80 and then back to 0 again as it starts to fill up with blood, and then the pressure rises again. So once it reaches your maximum ventricle pressure, the valves open and allows the blood to flow out. Resistance refers to the opposition to blood flow principally as a result of the force or friction between blood and the walls of the blood vessels, and the viscosity created by the RBCs and plasma proteins. Resistance is related to blood thickness, blood vessel length, and also blood vessel radius. So resistance is this. So blood in a pipe should be flowing naturally, but because the blood is rubbing up against the walls of the vessels, it's causing some type of friction. which will allow the blood flow to slow down or resist. It's just natural. So if it wasn't enclosed in anything, blood would flow freely without any resistance. But again, it's touching the walls, causing resistance. So if the blood is thicker, what do you think is going to happen? Are you going to have high resistance or low resistance?
High.
You're going to have higher resistance because the blood is thicker, and then also the vessel length. Vessel length, think about this, the longer that the blood has to travel, the more friction it causes, and eventually it's going to slow down. Increased resistance, decreased flow. You follow? So I have momentum up here, but the longer I have to travel, there's more resistance and less flow. So this is where blood vessel length comes in. And then blood vessel radius, the less contact that the blood has on the larger vessel, you have more flow, less resistance. But the smaller the vessel, more of the blood is going to be rubbing up against the vessel walls, causing more resistance, less flow. Does that make sense? I think I explained that all in this next few slides. So, blood viscosity is the ratio of the RBCs in solute to fluid. Resistance to blood flow is directionally proportional to the viscosity of blood. In other words, the thicker the blood, the more the resistance. Well, how do you get increased viscosity? You can get it through dehydration. How is that possible?
Less water.
Less water. Remember, blood is plasma, 90-something%, right? Water is a suspension for the blood cells. So if you don't have enough water, the blood is going to be much thicker. Polycythemia is an overproduction of blood cells. Okay, so now the ratio is greater with blood cells to water, making it thicker. And then severe burns also does the same thing, because with severe burns, you're a bit dehydrated from the injury. Decrease in viscosity, this is probably opposite right here, less blood cells, making the blood more watery, less viscous, and also hemorrhaging will also decrease viscosity. And then the blood vessel length, as we said, is directly proportional to the resistance to the blood flow through the vessel. So a good analogy would be something like this. I don't even know why this is up here. Let's look at this for a moment. Okay. When you turn on, let's just say your spigot, the force of the water coming out of the spigot is very strong. You guys agree, right? Now let's attach a hose to it. When you attach a hose to it, the water coming out from the end of the hose is going to be a lot weaker than if it was coming out of the spigot directly. Because the water is traveling long distances, as it's going through the hose, you have more friction. The longer you have to travel, the momentum starts to slow down. We have more resistance. And that is why at the end of the hose, the water just trickles out instead of shooting out like it would out of a spigot. And then the diameter. So resistance is inversely proportional to the fourth power of the radius of the blood vessel. That's going to be on the test.
Thank you.
Just kidding. That's not going to become 2 minutes. But going back to what we just said, do you know what that means? Resistance is inversely proportional to the fourth power of the radius of the blood vessel. All right. So I think what it means is the smaller the radius of the vessel, the greater the resistance. It offers to blood flow. For example, the radius of a vessel is decreased by, by 1/2 its resistance. Okay. Smaller the vessel, the more resistance. Okay? Because there's more of the solution coming in contact with the wall vessels. What just happened?
It's a salesman. Works in the
Oh. Do we not have class in here?
We do now.
We do, right? Okay. All right. So, just imagine it again, if you will. I'm going to draw blood in blue. So if
Makes
this
sense.
is blood, you have more blood coming in contact with the wall, so there's more resistance. But if you have this, the blood is only resisting on only a portion of the vessel, so this is more, you get more easier flow than this because there is less contact of the fluid with the vessels. Whereas here, you have more contact with the walls of the vessel, causing more resistance in a smaller diameter. Okay. Resistance increases as arteries get smaller. And we say they get smaller the further that they are away from the heart. So although the aorta is large, pressure remains high because of its close proximity to the heart. So the farther the vessel is from the heart, pressure starts to drop. Pressure drops from 80 to 30 at arterioles and capillaries, and then 10 at the capillaries and venules. And by the time it reaches the vena cava and the right atrium, it is 0 pressure. Circulation time is the time required for the blood to pass from the right atrium through the pulmonary circulation, back to the left ventricle, through the systemic circulation, down to the foot, and back again to the right atrium. The average circulation time is about 1 minute. That's pretty fast. So we talked about the 0 to 10 pressure on the veins. And so we have the valves, one-way valves, unidirectional valves, and muscle contraction that will allow the blood to return back into the heart. The concept of the muscle contraction is known as milking.
No.
I'm waiting for your response.
No.
Okay.
I say no.
Breathing moves. Breathing also aids in the diaphragm moving, allowing the change of pressure within your chambers in your cavities to also allow the movement of blood through your vessels. Okay, I think we're getting pretty close to finishing. Are you guys okay with that?
Yeah.
Okay. Veins of the upper limb. So let's talk about the upper limb again. Our scope of practice, technologists, is venipuncture is only, first of all, when we do a stick, it's vein. Second is upper extremity. So we're going to study the anatomy of the upper arm. There are 2 sets of veins collecting blood from the upper limb. One is superficial, the other ones are deep. The superficial veins are the ones that we're going to be working with. So there are 3 basic superficial veins. The first one is the cephalic vein, and when we read this, also refer to the picture here. The cephalic vein starts in the anterolateral aspect. It goes medial, and it makes its way up, all the way up here, into the axillary and then the subclavian vein. Axillary means what?
Armpit.
Armpit, and there's your subclavian vein. Okay, so here's your cephalic. It starts from here. Okay, ascends along the anterolateral anatomical position, thumb side. It starts there, makes its way up in the middle of the arm. It connects with the axillary and then the subclavian vein. Okay, next one here is the basilic vein. Okay, the basilic vein is it starts off in the posterior aspect, and it wraps around anteriorly, around where the elbow is. It comes up, and then it connects here to the basilic vein, the upper basilic vein. So it goes up this way. So ascends along the posteromedial surface, wraps anteriorly below the elbow, and it passes up medially up the arm. Oh, and also connects to the axillary up here too. And then the median antebrachial vein is this one right here. Ascends on the anterior surface of the forearm and joins the basilic right around the elbow. So this joins right around the elbow right here. So when you're looking at this graph over here, look at where all these veins converge. Right in the middle of your elbow. And this is where venipuncture generally occurs because you have all these veins. They're nice and plump, they're very superficial, hopefully easy to access, okay? And that's generally where we do our venipuncture. Now, can we do venipuncture on any other one of those? Well, yes, you can, but you really truly can't see, most of the time, you can't see the cephalic vein or the basilic vein of the upper arm unless you're really, really muscular or unless you are thin, where the veins are very prominent. But for the most part, you don't see them there. You only see them right here. And a lot of times you don't see them in the forearms either. You see it here, in the crooks of your elbow. So by the way, this crooks of the elbow, you know how it dips a little bit? Okay, that region of where all these veins are, that region is called the antecubital region. Antecubital region or antecubital fossa. So this area right here is known as the antecubital region or fossa. Antecubital region or fossa. Those were the superficial. And then we have our deep veins, which begin as small veins in the hand. The veins accompany arteries that have the same names as the arteries, including the ulnar, radial, and brachial arteries. So you have the two ulnar veins and two radial veins join. Oh, this is confusing. I think this is written wrong. Because when it says two ulnar veins and two radial veins, it's talking about both arms. Okay. This is so when you read this, it's referring to both arms. It's really, it should say, if we're talking about one arm, it should be the ulnar vein and the radial vein joins to form the brachial vein. That's what it should say. Yeah, that's kind of eluding. You guys get that? Mm-hmm. Okay. So ulnar vein and the radial vein joins to form the brachial vein. And then the brachial vein forms the axillary vein, and then the axillary becomes the subclavian. That's what it should say. All right?
Ooh, nice.
So I took a picture of my arm last week.
It's a Hulk.
Yeah, I only wish. I only wish. Who's got an arm like that in the class? I'm looking at Brad right now. Brad, you got those veins, huh? Yeah, he's got those veins. You know how I know? I've been eyeing you. Yeah, he's got some good ones. All right.
So we can poke.
So again, here, guys, we have the cephalic vein. It goes up this way. Cephalic, okay, goes up into the you have the axillary and then the subclavian. You have the basilic wrapping around, right around this way, also meeting up that vein. So this area here, the crux of this, I'm not going to spend a lot of time here. I'm done. So this area here is known as the, again, this is the antecubital fossa. Okay, this is going to be a little bit confusing because it says median cubital vein. The median cubital vein, the other name for that is the median basilic vein. So when it's pointing to this, it's actually also pointing to part of the basilic vein. So this is also known as the median basilic vein. And here's the misconception. You hear, when you hear phlebotomists or nurses sticking you, they say, I'm going to stick your antecubital vein. There's no such thing as an antecubital vein. Have you heard that before? Mm-hmm. Never? Okay, I'm making it up. Okay. But you hear them say that the antecubital vein is no such thing. It's the antecubital region. But the vein in there are the cephalic and the basilic veins that we stick to get access. Okay. All right. Any questions? All right. So the material that we covered today, again, very, very elementary, I think. You guys will have a test on that next week. Yes?
No.
I need to look it up.
Scantron test.
Scantron test? Okay. How many questions?
Multiple choice.
25? Okay. Yeah, so only 25 questions next week, okay, guys? On the material we covered. There are going to be there are several questions regarding the different accrediting bodies. Okay, so there may be questions about the bill, some questions about junior cert, may be some questions about which states have a language regarding venipuncture in their statute. Okay, so review those few slides. Okay, it's not just about anatomy; it's also about the accrediting bodies that's going to be on there too.
Huh?
Is it good?
But wait.